disease. HER2. Anyone have any questions or comments about the ER breast section? It's a great question. You know, adding PR testing as a way to pick up hormonally responsive disease that's ER negative has always been a dilemma. I think most people feel it is a real biology, that although the ER pathway can be inactive and the receptor can be not present or not measurable, that PR expression is a predictor of hormonal therapy benefit. But there are some who argue no, it isn't, and that PR testing is worthless, and all we want to know is ER. Today, it's still uncertain. It's still uncertain. We do it, we measure it. Do we get ER negative, PR positive cases? Rarely. They're not very common. And we report them. Do those patients get treated? Probably mostly they do. Do they respond? Maybe on occasion, but less well than the true ER positives do. And one of the big problems is how do we measure whether they're responding or not? It's very subjective, isn't it? So there might be some question about how well PR positive, ER negative tumors really do respond to tamoxifen. So I don't really know, but we do the test and we still give the results.
Do we need to do the test on carcinoma in situ, ductal carcinoma in situ?
The PR test, or the ER and PR? I don't know. This paper out today says we need to be doing HER2 on DCIS. But certainly ER, PR, yes, because we have a strategy for chemoprevention using tamoxifen or other anti-estrogen therapies. So if we know our DCIS is ER positive, and the patient's going to be placed on a chemoprevention with tamoxifen. If it's ER negative DCIS, there may be a more surgical and radiation-oriented treatment for that patient, thinking that the tamoxifen is unlikely to benefit them.
What did you say about the HER2?
Well, there's another study out today, but it's nothing new. I don't know why. It's all on the news, that HER2-positive DCIS has a greater risk of relapsing as invasive disease. Therefore, we should measure HER2 on DCIS, and we should begin to consider the anti-HER2 targeted therapies, the lapatinib and, of course, the trastuzumab, in a chemoprevention strategy. There is a chemoprevention trial just doing this. So the point is, a little paper here or there that says DCIS that's HER2 positive is more aggressive. We've known that for 25 years. Maybe that's too many years. We've known that since about 94. So we've known that for about 15 years. So that's not it. It's, well, the trials show that trastuzumab use as a chemoprevention creates a improved outcome for those patients. And if it does, then HER2 testing, I guess, will become standard, although as a pathologist, we know looking at DCIS, which DCIS has a chance to be HER2 positive just on the H&E. And those well-differentiated ones and the clinging type, they're never HER2 positive. And the comedo carcinomas are where you find them. You don't know if it is or not, but you could say, I don't have to, but I'm certain if it gets into practice, it will be for all DCIS. DCIS, again, if you subtype to the high risk, which we do the pleomorphic and the comedo, it goes up significantly. And you can be talking there at a rate that's equal to or even higher than the invasive cancer rate, 30, 40%. If you take all-comer DCIS, it's much lower because the well-differentiated DCIS is never HER2 positive.
One's with the high mRNA there.
The ER high mRNA, yeah.
Do they have a dichotomous event, like an activated mutation or something?
Well, that's a wonderful question. The estrogen receptor alpha mutation data is not very robust because the techniques used to detect the mutation have varied from study to study. But when it's been found, there's a couple of things that are important. Firstly, the antibody that we use for the IHC test is directed towards the portion of the estrogen receptor protein that's not affected by the ER alpha. The ER alpha mutations truncate the protein. And the part that's truncated is the ER, the estradiol binding domain, the functional end. Our diagnostic is directed towards the non-functional end. So when you get an ER alpha mutation, the patient is functionally ER negative, and downstream the pathway is silenced. But the IHC test is positive because it doesn't detect that the protein has been truncated by the ER alpha mutation. So it's non-activating, it's usually inactivating. There's not a lot of it. There's also a rare ER alpha amplification. And we developed a FISH test for ER. And we thought, well, we're going to have FISH for ER and FISH for HER2. And just knowing the protein status for ER wasn't enough. We needed to know the gene status. And there was excitement that the gene amplified ER. And the first studies said it was low, 5% of cases, 4% of cases, was going to be the ones with that big mRNA. And those were the ones we could treat with hormonal therapy alone, regardless of pathologic stage. But attempts to validate that first study have all failed. So right now there's no FISH testing for ER, and doesn't look likely that it's going to come on, much to my chagrin, because I thought it was a great idea. But if we have to do it by mRNA, we have to. But I'd love to be able to say, yes, you have metastatic disease to your lymph nodes, but you're so dependent on ER, we probably can't ever cure you, but we can palliate your disease for the rest of your life with hormonal therapy. You'll live with it like arthritis or something like that, and we'll always keep it under control. We can never eradicate it. We can't give cytotoxic drugs because those cells won't die if you give it to them, but we can block that hormone from stimulating it, and it's going to go to sleep for years or maybe decades. And when it comes back, we're going to have therapy to treat it again. Because the thinking is these high mRNA ones don't mutate into ER negative downstream. They stay ER dependent for their entire lifespan, these tumors. But it's work in progress, and it's certainly not been proven by prospective trials. Will CISH be the kish of death for FISH and IHC? Is the new non-fluorescent gene-based test, recently FDA approved for HER2 testing, got the potential to replace both the current FISH and the IHC test? The answer is yes, it does. Will it, though? I thought so 2 years ago. But poor marketing, failure of the second test, which is the more robust one in the sense that the company that owns it now owns trastuzumab, Roche. So Roche owns Ventana, who makes the second test, which failed to get an FDA approval, and Roche owns Genentech, which makes the drug now worldwide. So it seems like that company would like to see a non-gene-based, a non-fluorescence-based gene test, namely chromogenic in cytohybridization, be the test of choice. We'll have to see about that because this subject goes on and on. I should digress immediately to divulge. I worked on HER2-based testing using the FISH method, and I'm one of the patent holders for the test. There's 18 of us. None of us have ever received $1 for it. We're all stacked up. There's no royalties or anything. It's one of those kind of things you make no money, but your mother is very proud of you because you were able to do it. So I'm biased in a sense that I've never done an IHC test for breast cancer for HER2, but I'm poised as all get out to do my stomach cancers now. I mean, the reason I say that, I'm kind of putting the end in the beginning, but recently, of course, there was data that shows the first time a survival benefit for a trastuzumab platinum combination in metastatic gastric cancer. That would likely make me think that there'd be an application for an extended claim that this drug now can branch out of breast cancer for stomach. But I can't do FISH for gastric cancer. And the reason for that is, for some totally unknown reason, breast cancer is unlike every other solid tumor that's been tested. It seems to virtually only show an overexpression of the HER2 protein on the cell membrane when there's increased copies of the gene itself. And you don't get this dysregulation, or we call it FISH negative, IHC positive, except very rarely in breast cancer. But in lung, in GI, stomach, colon, in pancreas, in prostate, bladder, kidney, all these other, ovary, endometrium that's been tested, single copy overexpression is very common. Lung has like a 3% amplification rate, FISH positive 3%, IHC positive 21%. Stomach, 2 or 3% FISH positive, way up 18% IHC positive. So the test we'd have to do for stomach cancer will be the IHC test, so we won't miss all those HER2 positive cases that don't have an increased copy of the gene. But in breast, I've always and only done FISH. First, we did it in '96, and I was very, very excited about the potential of the test and learned about the development of the targeted therapy. And I'll tell you a little story about that when I put up this arrow of development. But we'll talk about whether FISH has any chance to grow and become the standard. Today, based on polling the oncologists holding their little handheld voting devices at the last NOCR Las Vegas meeting, 20% of cases in the US today are FISH-only tested. There's no IHC triage, and 80% are in the IHC triage. IHC first, 0s and 1s considered negative, 3+ considered positive, and 2+ is equivocal and triage to FISH.